Adulteration. I have to say that this talk today was inspired by my clinic last year in the help of Dr. Raul Gutierrez and Dr. Who finished this program. And a lot of this came from our peace conferences that we would do once a month after our clinics, and just talk about themes that would come through with our patients. As you can imagine, my clinic has a lot of immigrant families in it, and immigrant children. Mostly Latino children, but certainly from other areas of the world as well. And so a lot of themes kind of came through, and we were able to collaborate and talk together and really try to pull up those themes a little bit more intentionally as we move forward. So with that, today we're going to talk about acculturation and well-being for immigrant children and families. Now, I had a little trouble in how to present this information to you today. You are all a group of very intelligent people in the field of psychology, and I am dipping a little bit into your field, and I can certainly say that I'm not an expert. So I had a little trouble about how to present this, but what I thought was maybe I can come from this from more of a personal experience. And what is it that I do as a clinician, as a pediatrician, with my family, and why do these themes kind of pull through and working with Dr. Castro and Dr. Estrada. So, boring stuff, nothing to disclose. And then I want to start with a quote by Dr. Martin Luther King. I have the audacity to believe that people everywhere can have 3 meals a day for their bodies, education and culture for their minds, and dignity, equality, and freedom for their spirits. And so right off the bat, I just want to say that I'm coming at this from a social justice perspective, and seeing how acculturation and the ideas of acculturation contribute to our care to immigrant families. So we'll do the first two. We'll be very quick. It's just a rundown of defining immigrant health and demographics, and understanding how immigration functions as social determinant and impacts health. But we'll also explore the meat of the stuff of how acculturation affects health, mental health, and family dynamics, and discuss maybe some strategies to support resilience in the clinical setting. And I'm hoping that we have time for discussion, and then we can talk about that a little bit more, and see how we can do that in a more collaborative effort between our different disciplines. So I'm going to start off with just some terminology. So when I refer to immigrant, that's a person born outside of the U.S. To non-U.S. citizen parents. And then first generation is a child born outside the United States, now residing in the United States. A second generation is a child born in the United States with at least one guardian born outside of the United States. And sometimes collectively we talk about immigrant children, or also children of immigrant families. So any children born outside of the United States, or citizens that have at least one guardian born outside the United States. And this can come in many different flavors. For the most part, we don't talk much about border children, or those that live within 100 miles of the border. But I do want to point out that we sometimes see migrant children that come from the border to the Bay Area. And you might see that in other locations, maybe not here in San Francisco, but in other areas around the Bay. And so, in general, what is immigrant health? And I think that it's evolving, particularly in the realm of children. But historically, it's been really focused on refugee and legal new entry. Most of the guidelines have been for civil surgeons or panel physicians. It's focused a lot on adults and first-generation populations. Really, the focus is on communicable diseases. And we practice it a lot in refugee clinics, community health centers, emergency departments, and migrant health centers. And the studies are really concentrated on access, so coverage and language, and the state of health. There's a lot of information on acculturation, and that is very much evolving as well. And then policies that really prioritize cost burden rather than cost benefit of our immigrant communities. So in California, California is home to 10 million immigrants. That's 1 in 4 of the foreign-born population in all of the United States. And we see some fluctuations in the percentages, but California has always been home to immigrant families. And if we look a little closer up here to Northern California in the Bay Area, we see that a third of the population is foreign-born in Alameda, San Francisco, San Mateo, and Santa Clara counties. So really, any way that we approach immigrant health, whether it be policies, whether it's the way we practice, the way we talk about it, is really a public health issue. And the vast majority of California's immigrants as a whole were born in Latin America, 52%, in Asia, about 39%. The majority of recent arrivals making up the 51% in the past 5 years are from Asia, and that's our fastest growing population. Most immigrants in California are documented residents. 47% are naturalized U.S. citizens. 26% have some other legal status, and 25% of immigrants in California are undocumented. 8 of every 10 immigrants, 80%, are between the ages of 18 to 64. However, foreign-born residents accounted for 71% of state residents without a high school diploma and 31% of college-educated residents. So, very educated, but also not as educated on both extremes. And immigrants are as likely to be working as the U.S. born. However, they make less money, with the median income being about 14.8% lower than U.S. born households. And if we look at children specifically, California alone holds 25% of immigrant children. And within California, 4.3 million children live in immigrant families, with 90% being born in the United States. Really, so when we're talking about immigrant children, most of the time we're really talking about American citizens. So, in the Bay Area, children in immigrant families make up a little over 50% of the population, just in the Bay Area. The age varies, but we can see that first-generation immigrant children are mostly in the adolescent range. Your first generations are going to be your foreign-born children of immigrants that are mostly adolescents, early adolescents and adolescents. We also see that for first-generation immigrants are mostly, again, the trend stands true, mostly Hispanic or Asian, as well as our second generation, which is a little bit different from our native-born communities in the Bay. And then, again, the vast majority of our immigrant children are citizens, but on the non-citizen side, we have another kind of way of categorizing our immigrant children. So whether they're lawfully present, undocumented, permanent residents, refugees, asylees, or other lawful statuses, and we'll see different types of immigrant families in our clinics depending on where we're practicing. So if you're at the Family Health Center, you might actually see a lot of refugees and asylees. If you're at 6M, it's mostly going to be undocumented children, Central American unaccompanied minors, or children whose parents are immigrants. And then if we look a little bit at social determinants, the same trends hold true for the Bay Area. Most children live in working families, more so than native-born families in the Bay Area. As you can tell up here, it's a little hard to tell the numbers, but 94% versus 87% of families in the Bay Area are working. However, the disparities of low-income working families is pretty striking. And you can see quite a difference between, depending on where the families are coming from. So low-income working families from Mexico or from other Central Americans are above or near or above 50% compared to 3% of those coming from Europe. And if we factor in whether you're documented or undocumented, we see that undocumented workers earn much less. And undocumented working earnings do not increase substantially over time. They're stagnant despite years living in the United States if you're undocumented. And you can see that quite clearly. Yellow is in the U.S. less than 10 years, and blue is in the U.S. 10 years or greater. And then we see that our unauthorized aliens in this particular graph is pretty much the same in terms of of earnings. And we also see that poverty is more common among children of undocumented parents. As to be expected, poverty is more common in immigrant families, but we can see here that children in immigrant families that are undocumented have equal rates of poverty, despite the child being an American citizen. And so this is your last column right here. American children, first generation immigrant children in unauthorized migrant families, the poverty rates are pretty similar. And here we see that education levels are not very far off between immigrant and native parents overall, but there is significant variation amongst groups with Central American and Mexican natives having the lowest educational levels, and we see higher levels of parents that are not English proficient across the board. And then we also see that, and again, undocumented status skews these rates to a higher level as well in terms of education rates. And then we see that undocumented youth are less likely to continue their education or matriculate from high school as well. All right, that was the boring stuff. A lot of information there. So what does it all mean? Why do these differences in social determinants and health outcomes and some of the health outcomes that we didn't talk about exist? What are the driving factors? And even when immigrant families are doing objectively well or not well, why do some still exhibit outcomes that are unexpected, right? And how does this play out in the exam room? So these social determinants and others shape the way immigrants and children in immigrant families experience life, and they predict health outcomes. It seems to do so for other groups. However, why is there so much variation? We ask how and why highly acculturated youth may fare worse academically and developmentally than their less assimilated peers. And so we talk about the immigrant paradox and generational health outcomes. And we measure things like length of stay, language proficiency, and nativity to somehow, some way get an answer to these questions. And so we land at acculturation. On this concept of acculturation that tries to make sense of these things. Other definitions of acculturation we see here are changes that take place as a result of contact with culturally dissimilar people, groups, and social influences. And they can take place with any intercultural contact, most often studied in individuals living in countries or regions other than where they were born. It's really focused on immigrants, refugees, asylum seekers, or those who are coming to the country for like education or temporarily for work. Assumed to be permanently settled in their new homeland, and for the most part from the perspective of the United States being the dominant culture. And then we can talk later about what that dominant culture is. And then other definitions add things like adaptations to attitudes, identities, and behaviors as well. So, let's take a look at acculturation. So early on, we saw the forced assimilation of Native Americans with policies in the late 1800s, such as kill the Indian, save the man. This model expects that as groups acquire values, practices, and beliefs to their new homelands, in this case, not their new homelands, they were expected to discard those from their cultural heritage. And continually, we see that these approaches do not work and have generational consequences as a whole, generational consequences of a whole population. In such assimilation models, there's been added the idea of being bicultural to accept that some retain both cultures, but it still suffers from the limited linear approach and the idea that complete assimilation is optimal. And it ignores the layered components that make up identity, as well as the dynamic aspects of culture, and restricts the person or group in a duality, one or the other. So it evolved, and we took a more adaptational approach, or a bidirectional approach. So in the 80s, Barry's framework came forward with underlying strategies of cultural maintenance and contact participation This adaptation to the stress of acculturation could be divided into 4 groups: assimilation, marginalization, integration, and separation. Those in the integration section are bicultural and thought to be the optimal outcome. This, however, implies a strategy, that there's a choice in the matter and some element of control in the way you're acculturating. It also ignores that the idea that this process is dynamic, and one may shift from one strategy to the other throughout their lifetime. And how do the greater sociocultural influence interact with these acculturation strategies? What's the context? And so some models have evolved and also included those of the larger society. But this does not take into account how larger societal factors interact with those of the group. There's no critical examination of what it means to be a dominant culture and the existence of institutionalized oppression. This does not fully acknowledge the dominant group's power to establish social structures in all social, political, economic, and cultural domains. And where's the resolution? How long does this process take? How do you explain or reflect one's experience in identity development and ultimately mental health outcomes or the psychological outcomes? So then we have interactive models. And so now there are a host of interactive models that take into account external factors that influence or moderate the acculturation process. However, how do we measure this in clinical practice? How do we ascertain where one is in the process or how they decided to engage in that process? And for those born in the United States, is the acculturation process their own or an extension of the caregiver and or group? Are child and parent doing this in parallel or as a unit? And when does this process end? How many generations out does acculturation happen? So, does any of this explain anything? And to some extent, the interactive models can help take us out of the unidirectional and bidirectional models and force us to look at multiple aspects that influence what we call acculturation. But what we discover is that the outcomes are variable and dependent. Sometimes these paradox phenomena happen, and sometimes they don't. To me, in the room, there is no paradox. But rather, the paradox is an attempt to define something we don't really understand. And the concept of the paradox is only an indication that I myself must step out of these frameworks and try to understand the individual process in the clinical setting. So, I'm going to go into a little bit more of how I approach things, and I had to dig really deep to figure out, like, why do I do these things? Why do I answer these questions? Why do I engage in conversations with my patients and their parents about how they relate to each other, depending on where they're coming from, where they are in the generational immigration identities, and how that plays out in conflict within family structures and those outside of the family structure. And so I had to go back to some college reading. And I drew, I think, inspiration in reading some of these passages a little bit more from Gloria Sandua and her book Borderlands. And so there's this concept of nipanta. Yeah? It's a Nahuatl word which means in the middle. In the middle of it, or just middle. And the concept is used often in Chicano and Latino anthropology, social commentary, criticism, literature, and art. And it represents the concept of in-betweenness, either here or there. And this concept has also been identified as a painful experience, where a person's sense of self has been shattered. And it can also signify a personal state of invisibility and transition. And Gloria Sandua describes the fact that as a time where individuals experience a loss of control and suffer anxiety and confusion as a result. And so we can imagine how that manifests itself either with mental health outcomes or even physical outcomes, depending on the age and the person. Gutierrez says, in the FAAP, you're exposed, open to other perspectives, more readily able to access knowledge derived from inner feelings, imaginal states, and outer events, and to see through them with a mindful, holistic awareness. Seeing through human acts, both individual and collective, allows you to examine the ways you construct knowledge, identity, and reality, and explore how some of your or others' constructions violate other people's ways of knowing and living. And so she also gave us the theory of the borderlands. So the borderlands are present wherever two or more cultures edge. Wherever two or more cultures edge each other, where people of different races, for example, occupy the same space. These borderlands establish differentiality and are socially constructed. Most often, these differentials create hierarchies and binaries with an us and a them and some aspect of power over the other. So the idea that acculturation has an endpoint for immigrants and children in immigrant families, I think, is a false one. It's always evolving, and orders are always presenting themselves. We too, as clinicians, have to be aware of the orders that we construct as providers, either personally or as agents of Western medicine. And so she says the struggle is inner. Chicano, Indio, American Indian, Mojado, Mexicano, immigrant Latino, Anglo and power, working class Anglo, Black, Asian. Our psyches resemble the border towns and are populated by the same people. The struggle has always been inner and is played out in outer terrains. Awareness of our situation must come before inner changes, which in turn come before changes in society. Nothing happens in the real world unless it happens in the images in our heads. Let's see if we can play this video. That's just little moments of fun and magic.
Yeah, that would be so cool.
I'm not sure of that right now.
Come on, Dad. Hey, Dad, you always said everything's a list, right?
They don't accept us with it. They never have.
Hello, we're Mexican.
No, we are Mexican-American, and they don't like Mexican-American. And they can be mean, and they can tear us apart over there. So then the Spanish is...
What about my Spanish? I've been singing in Spanish for 10 years. It's perfect.
Singing, yes, but when you speak it a little funny. And down there, you gotta speak perfectly, or the press will eat you up and spit you out alive. I've seen them do it.
Overreacting. Dad, the music will speak for itself, Dad.
Listen, being Mexican-American is tough. Anglos jump all over you if you don't speak English perfectly. Mexicans jump all over you if you don't speak Spanish perfectly. We gotta be twice as perfect as anybody else. Why are you laughing? What's so funny? I'm serious. Our family has been here for centuries, and yet they treat us as if we just swam across the Rio Grande. I mean, we gotta know about John Wayne and Pedro Infante. We gotta know about Sinatra and Agustin Lara. We gotta know about Oprah and Christina. And too bland, and yet when we go to Mexico, we get the runs. Now that to me is fantastic. Japanese Americans, Italian Americans, German Americans, their homeland is on the other side of the ocean. Ours is right next door, right over there. And we gotta prove to the Mexicans how Mexican we are, and we gotta prove to the Americans how American we are. We gotta be more Mexican than the Mexicans, and more American than the Americans, both at the same time. It's exhausting. Man, nobody knows how tough it is to be a Mexican American.
Well, Dad, you know, it's a good thing we have some whole different tortillas to keep our strength up for the job.
Now you're making me
No, I'm not. A menudo.
Hey, menudo, hey.
Menudo.
Now you're making me hungry.
Come on, Dad.
And so we see these interactions play out all the time at home, in our schools, in society in general. And it differs and it changes depending on where you live. And in some environments, it might be a little bit more accepting and it might be okay. I come from Brownsville, Texas, not far from Corpus Christi, where Southern Cal is from. And our community was probably 95% of Mexican heritage, but there was still that struggle. It was still there, it's still present, right? So cultural collision. As Abdullah again says, like all people, we perceive the version of reality that our culture communicates. Like others having or living in more than one culture, we get multiple, often opposing messages. The coming together of two consistent but habitually incompatible frames of reference causes un choque, a cultural collision. Some might experience this as culture shock. I'll add a little bit of that depending on where you're coming from or where you go. I did my undergraduate at Stanford, and that was a culture shock, going from Texas to California. And then I did my master's in public health over at the University of Michigan, and that was a much bigger culture shock. And it wasn't just the culture of the people, it was also the weather. But this plays out over and over and over again. And so I think children and youth are particularly vulnerable to these collisions. There's conflict in the perception of having to choose one or the other, and sometimes there are pressures to do so as cultural brokers. How they manage these collisions with family, school, friends, and society at large has an impact on identity and self-worth, and ultimately manifests itself in mental health wellness outcomes. I have another one. I don't know if anybody wants to read this, but
I've been translating my whole life. I started translating English to Spanish the way I saw white people do it. I just put a O after every word. My comedy special is called Translate This. Like most immigrant kids in America, their parents come here, they don't know how to speak English. As a little kid, I picked up English fast. I went from kindergarten to first grade. I was fluent already. My teacher told me, "You're failing math, mister." I was like, "Last night I did my mom's taxes. I didn't do my homework. I'm filling out disability forms."
And so sometimes we see this stress play out and when we see kids. And we're trying to discover where it's coming from, what is going on, and despite them being assimilated or acculturated, whether they're third or fourth generation, some of these aspects are still there. Some of these aspects play out. Sometimes they're in stories, right? Maybe my father had this experience and I heard stories of those experiences. Somehow I've lived that experience as well. And so there are examples of how families as a whole are going through this acculturation process. But then sometimes the individual is going through their own acculturation process. And are they doing it together? Are they doing it in contrast? Where are they in that aspect? And we see, I know Brody and I used to see a lot of this conflict between our parents and our kids in trying to play out what the expectations are. What are the expectations of the parents and what are the expectations of the child? And those are informed by culture on both sides or multiple sides. So, mestiza consciousness is kind of where Gloria Sandua came to a conclusion in her book, in Borderlands of Frontera. I encourage you to read it if you haven't read it. It's a fantastic book, and it has a lot of these examples, and it's written in a very fascinating way. But if you haven't read it, please try to pick it up and read it. It's really a classic text. So by creating a new mythos, that is a change in the way we perceive reality, the way we see ourselves, and the ways we behave, now mestiza creates a new consciousness. The work of mestiza consciousness is to break down the subject-object duality that keeps her prisoner, and to show in the flesh and through the images in her work and her duality, and her work how duality is transcended. The answer to the problem between the white race and the colored, between males and females, lies in healing the spirit that originates in the very foundation of our lives, our culture, our languages, our thoughts. A massive uprooting of dualistic thinking in the individual and collective consciousness is the beginning of a long struggle, but one that could, in our best hopes, bring us to the end of rape, of violence, of war. So understanding that acculturation as a concept is flawed, in my opinion, and doesn't answer all of our questions, that it is only a tool to begin exploring behaviors, identities, and this process of belonging how can we help our immigrant communities in the clinical setting? This is where I hope we get to discuss, and you can help me figure that out, because I don't know the answers. So we definitely default to common tools. Yeah, cultural competency, which has now given way to stuff like cultural humility, multicultural healthcare, the concepts of cultural matching, right? Who are we hiring, who's in clinics, and what does that mean, and how is that helpful? Sometimes it means taking things that we already do, like a head assessment for us in adolescence, and adapting those a little bit, right? So asking things like age of migration, language proficiency, cultural and personal identity, family structure and cultural identity, pre-migration and migration experiences, discrimination and social exclusions, education barriers, generational statuses, and really trying to get a whole picture of who this person is in the context of their society, and the context of their families, and their context of their education, and trying to piece this all together. In particular, with my unaccompanied, with the children that I take care of, are unaccompanied minors from Central America, both at the school-based health centers and in here, we really had to move away a little bit from this concept of really just thinking about the pool of why people immigrate. So safe haven, reunification with family. The big one in the narrative is education and work. Everyone's coming here for education and work and to have a better life. They should be grateful that these things are there for them. But really, there's a lot of push as well. Active poverty, violence, community or family violence, lack of protections, trafficking, labor, and sex. And that migration experience really defines and frames the experiences when they get here, right? And what is that experience? How does that experience, how do those stories, how does those feelings of self-worth or those feelings of surviving then get translated to the next generations, right? And then within the context of whether you're in a society that's welcoming or not welcoming. And so I think those are very important. And so with some of my Central American unaccompanied minors, we thought about these things in very different levels. So we thought about their pre-migration experience, their migration experience, and their post-migration experience. And it was very easy for us to just go directly to the pre-migration. Tell me about your trauma. I want to know about your trauma. How can I help you around your trauma? But this process of belonging and wanting to be here, this process of being in the in-between has already started by the time we've gotten here to the United States. And really, a lot of the stuff they wanted to talk about here. Yeah? How do I figure out, how do I maneuver where I am now, this place that I now am supposed to call home? And so that was very enlightening for me to change my framework a little bit. That doesn't mean the trauma doesn't matter, but sometimes other things are a little bit important, rise to the top. And so, just to kind of put this in a more artistic kind of point of view, and from a Somali poet, an immigrant, this is a part of Kenyan-born Somali poet Warshan Shire. It's a very beautiful poem, and I just have an excerpt here. You have to understand that no one puts their children in a boat unless the water is safer than the land. No one burns their palms under trains beneath carriages. No one spends days and nights in the stomach of a truck feeding on newspaper unless the miles traveled mean something more than the journey. No one crawls under fences. No one wants to be beaten, pitied, right? So these experiences are very powerful, and again, it frames a lot of how we adapt to new environments and new homes. And so what can we ask about? What are the things that we can do? So we can take this kind of idea of protective factors. There's a lot of evidence out there that shows that there are some protective factors, but again, it's very linear. It's very just like, we're just going to look at this one thing. So we have to take that information and really look at it as a whole. So are there positive family dynamics, family connectedness, perceived child-parent cohesion? cohesion, supportive parenting with bicultural elements, bridging the child-patient acculturation gap, positive peer relationships, strong senses of identity and belonging with family and at school, participating in extracurricular activities, engaging in meaningful activities. Sometimes a lot of the Central American Unaccompanied immigrants that we saw didn't need intensive therapy. They didn't need long-term therapy to work through their trauma. Sometimes they just needed a group. Sometimes they just needed community. I don't know if some of you have heard of Fuerte, which is one of the groups that occur within the school system at the wellness centers. And having that space to talk about these things and explore one's identity, to explore that space of otherness, of the in-between, can be really powerful for people and jumpstart them into that process. And then we know that identity development may also be affected by other things, right? Racism, discrimination, marginalization, lack of value placed on their experiences, these questions of belonging, conflicting values and belief systems, and again, acting as cultural brokers. So, kind of looking at immigration as a modifying factor, we have to ask some of these questions. How does immigration status, history, and identity affect life within these systems at all levels? Whether it be the individual, interpersonal, organizational, community, or public policy. How does our knowledge of a family's immigration history inform our clinical decision-making, our policies, and our network of resources? And how do we change the narrative of deserving versus not deserving when we approach these youth and the services that we give them? And I feel that there's a lot of struggle with public opinion on immigration as well. And sometimes that may influence our own actions. As a topic that becomes strongly politicized within governments and the media, and in direct conflict with human rights and social justice advocacy efforts. And sometimes those can be very real, right? Who knows with federal funding, what's going to happen with federal funding? Our dreamers who are DACA recipients have reached yet another border that they have to deal with, right? Their identity, again, has been stripped and redefined in a very short period of time in their lives. And so at some of our clinics over at the school-based health centers, we take this kind of ecology of needs approach with this idea of resilience and ready to learn. And we took all these kind of different aspects that came out of working with these youth. And really the part that we struggle more with most is mental health and support systems. Right? The legal, the insurance coverage, the medical is very concrete. And we can kind of deal with that and we can work with the systems. But the mental health and support systems has been particularly challenging to kind of redefine these frameworks, taking models and then trying to fit them into something that's culturally appropriate. CBITS is a very good example that sometimes it just doesn't work with some of these populations. And so we want to do something similar here at 6M as well. We started the Bridges Clinic. Right now it's in its pilot phase. Eleanor, over there, Dr. Chung, is my co-director for this. And Dr. Martinez as well has been helping with this a lot. And so right now we're just in a pilot phase. And so we're using it right now as kind of a specialty clinic. So really taking those immigrant families, those newcomer families who are at highest risk and trying to really do a lot of wraparound care. The idea over time is to kind of take these concepts and take these practices and hopefully that the whole clinic will pick up on these approaches and then that we really will just focus on those cases with a specific type of help. However, the one part that we're missing is our integrated approach. So we're going to take a tailored primary care approach and so introduce this concept of medical homes, and we have these established guidelines and standardizations and medical legal partnerships, and we're establishing policies and procedures and reaching out to our community-based organizations and our school districts. But then this kind of mental health screening and individual and group resources type thing is kind of like, oh, how do we do that? Right? How do we take these ideas of acculturation and trauma and toxic stress and social determinants and put it all together? And I don't know that anybody does it really well. But I'm hoping that this provides some inspiration, and that maybe as a collective we can learn how to do that. And so I leave you with this last video before we end up and see what kind of questions or discussions we have. Uh-oh. Let's see. Oh no, I really want this is my favorite one. Oh, I'm so sad. I don't think so. But if we have internet connection, I can find it. Oh, perfect. All right. Do you want to help me with that?
Yeah.
Oh, that's a little tricky. I think we still have some time. Like 15 minutes on this video. It's only like 5 minutes. It's not. Alright, I'm going to try to be really quick. No, that's not, no. That is another person. How am I going to there we go. Amazing.
Like most kids, I just wanted to fit in.
Uh-oh.
Like most kids, I just wanted to fit in. But for me, that meant secretly harboring this unfulfillable desire to be white. What does my tattoo say? Sa-fi means split in Chapter. Chitino, it's the indigenous language of the Oaxacan family. I was born in Oaxaca to a Chitino mother and a father from the Isthmus. I was taken to the U.S. when I was a baby, and I spent most of my time going back and forth between Mexico and the U.S. In the U.S., I'm brown, I'm exotic, I'm Mexican, I'm an immigrant. In Mexico, I'm American. In Oaxaca, I'm maybe Chilanga, if not, then just definitely not from Oaxaca. Plus that, even white people try to question my indigeneity. Yes, I am indigenous. I am a Latina, Ismeña, Mexican-American woman. Chitino was my first language, Spanish my second, and English my third. My family has been working to find ways to preserve and create an official writing system for Chitino since I was a kid. Well, yeah, lately I've been trying to relearn Chitino. Mi son, Dani. That's the way that people greet each other in Sinigia. Wash, wet, that's thank you in Chitino. In the States, I mostly grew up in white liberal environments, and the communities I was exposed to as a young child were full of love, but I think it's hard to feel loved and accepted in a society that was founded and built upon racism. I was in pain because I was constantly looking outwards for, no sé, like guidance, approval, acceptance. It wasn't until I looked inwards that I was able to regain my strength. The strength I was born with. Oaxaca is a part of that strength. When I go back, I return to my center. I become grounded. I remember I have roots that reach so deep, it's actually impossible for anything to knock me down, pull me out. I'm physically small, but the strength I was born with is bigger than me, richer than me, deeper than me, and still a part of me. Yeah, I'm also American. I realize it's not me that's corrupt and corrupted. It's the ones that say that I don't belong, that I don't exist, that I don't matter, that people like me don't matter. Those people are the broken ones. Because what they don't realize is they're killing themselves too. I was always afraid of being the other. I wanted to attach myself to a single identity. I have let go of China shoes and have become more fluid, like water.
Alright. That's all I have for you. So, I'm happy to take questions, or maybe we can discuss, particularly around how do we help youth and immigrant families have these conversations, how to break out of this duality of letting something go only to take something in, and breaking away from that framework of having to do that you can be all these multiple things and still live in this country and have a positive experience. Experiences. Yes.
It seems like the task, there's like, you just break it up into some stages, right? And the task of defining what a particular social location is, right? Or a particular identity, and then kind of having the person be able to define that, and then you then toss it in, then you mix it all up, right?
Right.
It seems like it's a developmental stage in terms of language around it. And so that's the comment. That's the comment I have. I appreciate that you brought what I appreciate as a woman, and also the borderland being the term being mestiza and not mestizo. That thinking about the intersectionality of gender here, I think is really important. The traumatic experiences of boys versus the traumatic experiences of girls within the immigration experience can be vastly different. And so wondering how you think through that experience that you provide.
Yeah. So again, I think it's important to understand that, you know, when I work with immigrant families, I don't just think about where they came from and what language they speak and where they are in terms of their generational process. It's really trying to take in every aspect of them. And to me, when I speak to a youth and I see that they're not forming identity, whether that be male, female, or maybe that identity has been harmful to them because of it. So being woman, being queer, being transgender, or not conforming exactly to what is beauty in the magazines or things like that. You can see the difference, and I think it's important to pull all those aspects in together. And so yes, so those intersectionalities I think are very important. I think we find it challenging, particularly as medical clinicians, to have those conversations and explore those topics. And not necessarily that we have to dive in, but how do we even just bring them up? How do we explore them and then be able to communicate that with our colleagues and then be able to work together to come to some type of resolution or some type of plan for them. It's difficult. It's really challenging. I don't know, Dr. Castro, if you have any insight into that.
Well, let me start by saying Raul that it was this wonderful opportunity for me as the institution, as an institution, to work
Thank you.
And my sense is that one of the things that the impact from this establishment change and in another particular way to see your students was the opportunity that we as providers have systems where they can work with the needs that they actually have the psychiatric. And another thing that I found very interesting is the for example, is how do you balance, how can you balance the history of trauma that they had in their particular conflict with the fact that they are in a very particular stage of the immigration process, that's the cultural shock for them. And how do you need to address that in that particular approach? And we saw a lot of parents who were having a lot of conflict with their behavior of their youth, and in reality it was a reflection of how the parents were in a very particular immigration system, and how we were able to open that conversation, and how that was related to the behavior that they were concerned about the child. But I think that in a way we as providers, and make of the providers of the before generation, we really need to be courage to step out of our box,
Yes.
and to be able to be where they can.
Right, absolutely. Right, and inadvertently, sometimes parents, teachers, maybe even sometimes us, and the way we counsel, create more of those collisions, right? We make them happen even more, right? So, having a brown-skinned boy out in this particular environment and encourage them not to speak Spanish or whatever language they speak, but then society as a whole keeps reminding them that you're different. Why don't you speak this? Aren't you going to speak a different language? Those collisions are happening all the time. And while certainly we talk about, complex trauma, traumatic experiences, ACEs, and things like that, I feel like sometimes the stress of this acculturation process can also last so long and be so traumatic for a person in certain situations that it causes some of those same clinical outcomes. And we know that we see that from generation to generation as well, right? When we talk about these paradoxes, right? And really kind of dissecting why does this paradox really exist, and why are we calling it a paradox? Why does it have to be this way?